Let's jump right into the explainer. When you're evaluating a witness spell, your immediate priority is to sort out exactly what happened. We're going to use a structured clinical triage approach to figure it out.
First up, you need to determine if you're looking at an active seizure or an event that's already resolved. Next, figure out if this is the patient's very first seizure or if they have known epilepsy. Then, try to identify if the event was provoked by a specific trigger or if it was unprovoked. And finally, evaluate whether there was any trauma involved, like a fall. This whole branching logic is what dictates the immediate next steps in your management.
So, how do you differentiate a true seizure from a syncopal episode? You'll want to look for a prolonged post-ictal phase of drowsiness or confusion. If you see evidence of lateral tongue biting, incontinence, physical injury, or a stereotyped aura, those are highly specific for a seizure. Now keep in mind, syncope might present with some brief convulsive jerks, but movement alone is not enough to call it a seizure. Instead, syncope is typically preceded by a prodrome. Think pallor, sweating, a standing trigger, or cardiac risk signs, followed by a rapid recovery of consciousness.
Moving on to complications of generalized seizures. Acutely, they can cause hyperthermia and cardiorespiratory compromise. If a seizure is prolonged, it can actually lead to excitotoxic brain injury, specifically cortical laminar necrosis. You might also spot a post-ictal high anion gap metabolic acidosis, and that's just due to increased lactic acid. But don't worry too much about that one, because it typically clears up on its own within 60 to 90 minutes. Also, those violent muscle contractions during a seizure, they can cause physical trauma, like a posterior shoulder dislocation. And don't forget to keep in mind the long-term psychiatric comorbidities and psychosocial consequences for the patient.
Okay, let's talk about the workup for our first unprovoked seizure. If the patient fell or if head trauma is even a possibility, your first step is a non-contrast CT of the head to rule out acute bleeding or a structural emergency. An MRI is actually more sensitive for finding structural causes of epilepsy, but that's usually an elective procedure you do after you've excluded those emergency threats. Next, you evaluate for triggers and mimics. Check their glucose, electrolytes, get a CBC, look at renal and liver function, and do a toxicology screen. Run a pregnancy test if relevant, and check anti-epileptic drug levels if they're already on them. You'll also want an ECG to rule out a cardiogenic syncope mimic, and go for a lumbar puncture if you suspect a central nervous system infection. Finally, an EEG is what helps you classify the recurrence risk and the specific seizure type.
Now we'll look at focal seizures. These originate from a single cerebral hemisphere. Clinically, they can present with motor signs like a Jacksonian march or head and eye deviation. But it's not just motor. They can also manifest with sensory symptoms, like paresthesias or visual phenomena. You might see autonomic signs like sweating or an epigastric rising sensation, and even psychic phenomena, like déjà vu or fear.
We can break focal seizures down further. A focal aware seizure means there's no impairment of consciousness. The neuronal discharge stays localized to that one hemisphere. But if awareness is impaired, it means the seizure has spread into awareness networks in the other hemisphere. These focal impaired awareness seizures are frequently associated with automatisms. Think of things like chewing motions. Keep this in mind for the exam. The first focal seizure in an adult heavily suggests a structural or metabolic cause, which means they need an MRI and an EEG.
Let's shift gears to absent seizures. These cause a sudden impairment of consciousness, presenting as brief staring spells that last less than 20 seconds. The patient's muscle tone is completely preserved, and there's zero postictal confusion afterward. These spells can involve simple automatisms like eyelid fluttering or lip smacking, and they are really easily provoked by hyperventilation. The diagnostic hallmark you're looking for on an EEG is a 3 Hz spike wave discharge pattern, and the preferred treatment? That's ethosuximide.
You'll need to distinguish absent seizures from simple inattentive staring. While absent seizures can happen during literally any activity, lack a response to stimulation, and often feature those automatisms we just talked about, inattentive staring primarily happens during boring activities. Inattentive spells also last a lot longer, often well over a minute, and the patient will usually respond to vocal or tactile stimulation. You can snap them out of it. And unlike absent seizures, they don't have automatisms.
Next up is generalized convulsive status epilepticus. This is defined as either 5 or more minutes of a continuous generalized convulsive seizure or 2 or more generalized convulsive seizures occurring without any interval recovery of consciousness between them.
When it comes to managing status epilepticus, your first move is always to stabilize circulation, airway, and breathing, and then check their glucose. Your initial pharmacologic step is giving benzodiazepines, so lorazepam, diazepam, or midazolam. If the seizure activity keeps going, you administer an adjunctive IV agent like levetiracetam, fosphenytoin, or valproic acid. For cases that are refractory and just won't stop, you need to initiate a continuous infusion of midazolam, pentobarbital, or propofol and combine that with continuous EEG monitoring.
What happens if the patient is still unresponsive 10 to 20 minutes after you've given treatment? You have to distinguish between two main causes. It could just be lingering sedation from the benzodiazepines you gave, or it could be active, non-convulsive status epilepticus, which is ongoing seizure activity in the brain without the physical movements. To tell the difference between these two states, an EEG is required.
Moving to altered mental status, the triggers generally fall into four main diagnostic buckets. First, you have drugs and toxins, which includes both intoxication and withdrawal. Second, think about systemic and central nervous system infections. Third are metabolic and endocrine derangements. And the fourth bucket covers primary central nervous system events, like a head injury as well as psychiatric disorders.
Let's look at some specific, high-yield metabolic and systemic derangements that cause altered mental status. These include hypoxemia or hypercarbia, nutritional deficits like thiamine or B12 deficiency, and signs of hepatic or renal failure. Hypertensive encephalopathy is another major central nervous system cause that you always need to evaluate for. Finally, we evaluate the severity of altered mental status using the Glasgow Coma Scale, or GCS. This scores the patient's eye, verbal, and motor responses, with the total score ranging from 3 to 15. A key threshold to remember for clinical triage is that a GCS total score of 8 or lower is classified as severe.